All right, everybody. We have a shorter presentation today, but it's jam-packed with a ton of good stuff. It's almost every slide guaranteed it's got some good stuff on it. No, I don't know about that. I shouldn't make promises like that. But yeah, a lot of this is, I think, good. Updated for the ADA, which is American Diabetes Association. They came out with some new guidelines in 2017, and they've actually still been updating those guidelines in this year. We are in 2018. So stay tuned for some more, not necessarily from me, but I just mean stay tuned as a practitioner out in rotations and everything. There'll be some newer things kind of coming out from that organization in 2018 because they've already released a little bit of stuff, whatever. So anyways, let's just jump into it. Some of this is going to be repeated from the previous lecture on the diabetes medications. Some of it's new stuff, but like I said, I think it's all good. I think it's all good review and everything. But so anyways, this first off is just the criteria for diagnosis. Diagnosing diabetes, this is definitely stuff you're going to get in ICM. I just put it here for completeness sake, so definitely don't need to worry about stuff like this for my exam. So this is just here, just at FYI. Again, just for my exam. It's probably going to be probably relevant for ICM, probably going to be on their exam over there. Again, here too, just, how do you diagnose it? Just for completeness sake, another FYI slide here, just your hemoglobin A1C. Yes, they stand for something. When I first was going to pharmacy school, I didn't know anything about type 2 diabetes I'd heard about A1Cs, but I didn't realize they stood for stuff. So yeah, they actually mean something, right? So that's good. Couple of goals here. This is going to be relevant depending on your patient and the specifics of your patient, but then also what organization you're looking at. So you notice the endocrinologists have a tighter or a more stringent or strict goal of having a lower hemoglobin A1C of 6.5 versus 7. So again, FYI for my course as far as what the cutoff is, but 7, 6.5, almost the same. You'll notice they're about, in between 126 and 154 for blood glucose. But, don't worry about memorizing that for my exam, but probably relevant for your ICM exam. Treatment initiation. So this is where we're going to get into the pharmacology stuff, pharmacotherapy specifically. And this is where everyone needs to do the lifestyle modifications, which we've talked about. Basically it's just move more, eat less, stop smoking tobacco. And that's oversimplified, but, good diet, good exercise, etc. Right. And actually now both the endocrinologist and the ADA agree that the lifestyle modification should be done initially and then done throughout. So the patient should also be started on metformin unless it is contraindicated. So that's going to be your step one. Like I said, both of those agencies, I guess I should call them. So both the American Diabetes Association and the American Association of Clinical Endocrinologists both agree lifestyle modifications with metformin unless it's contraindicated. So hopefully you'll remember from my previous lecture, contraindications for metformin include a hypersensitivity to metformin or any component of its formulation, which is for every drug, right? You guys have been hearing me say that for everything. Always a contraindication. In addition, for metformin specifically, severe renal dysfunction, and that is defined as an estimated GFR of being less than 30. Another contraindication is acute or chronic metabolic acidosis with or without coma, and this includes diabetic ketoacidosis. So those are the U.S. Contraindications for labeling. Also note too that and the reason I say U.S. is because Canada and European countries have additional contraindications for metformin, but that's it for the U.S. So that's all we have to worry about for my exam and where majority of you guys are going to end up practicing anyways. In addition, in the U.S., there is a U.S. FDA box warning for metformin for the lactic acidosis. So again, make sure you're studying that, learning that for metformin. There's some exceptions here that both agree on. So basically, if their A1C is high or higher, so depending on the organization, ADA has it at 9, the AACE has it at 7.5. This is where you can actually do a dual therapy. So when there's one medication, it's called monotherapy. So majority of your patients will probably, and I guess I shouldn't make that prediction. I don't know where you're going to end up practicing, but um, so if your patient isn't has a really high A1C initially, you will start with monotherapy, and that's going to be metformin. So you can think of that as being your foundational medication here, metformin. And always lifestyle modifications, right? And then you go to dual therapy. So second, third line agents. Notice I put a ton of question marks here. So what is that? And this is where the art of medicine comes in, I guess we should say. This isn't, so everyone agrees metformin first, lifestyle modifications first. But then with second and third line, not everyone agrees. And it's hard to say, this is exactly what you're going to do, step 2, step 3, step 4. So for studying purposes, metformin, first line, everybody, right? Unless contraindicated. And then second and third line, this is going to be more tricky. And it's really going to be kind of patient dependent. Is the patient overweight? Are they not overweight? Are they old? Are they young? What's their kidney function like? What's their liver function like? What else? Can they be started on insulin? Do they like insulin? Do they not like insulin? There's a lot of different factors are going to come into play. Socioeconomic factors as well. Do they have access, or because some of these medications are more expensive than others, which we'll talk about here in a second. So can they afford the second line or third line agents? Can they not? Do they have insurance? Do they not have health insurance? Do they need to be prescribed something that's generic? Can they go to brand name, etc.? So students in the past have not liked me for this in the sense that they like it when, and I was the same way as a student, so I totally get it. They like it when it's, first line metformin, second line is this, third, when it's kind of a nice clear cut picture and kind of cookie cutter in the sense that you can just, first line, second line, third line, you can go down the line. But that's why I put so many question marks here. I should have put a frowny face or something, I don't know, or a student shaking their fist in the air at me or something. But yeah, so this is where, again, art of the medicine and a lot of different factors are going to come into play. So for test questions, for my exam, and I'm assuming for ICM, and then for your board exam, the second and third line, this is where you really need to pay attention to the patient, the vignette, they say, right? So you really need to pay attention to, does the patient have, do they drink a lot of alcohol? Do they have a bad liver, right? So that could affect some of these medications, just as one example. So anyways, let's get into it. So we mentioned already, I said it before, really nice for studying purposes, first line metformin. We have the brand name here. Don't worry about that for my test, just generic, but you hear people they'll call it glucophage. You hear people say metformin, and then metformina is Spanish for metformin. I learned that working in South Texas because people would bring their metformin that they bought from Mexico and they'd show it to me. I don't know why. No, yeah, they showed it to me, and there were some patients that I always asked if I could see what they got from Mexico, just because I thought it was kind of cool to see what they call it in other language, in Spanish. And but anyways, that doesn't matter. Not on the test. So yeah, first line, again, if not contraindicated, so please study and learn your contraindications, learn your box warnings, as always. Exception is where you can initiate insulin therapy. If, again, it is I would classify as maybe being a more severe or a bad, quote unquote, type 2 diabetic. So their hemoglobin A1C is greater than 10, or their blood glucose level is greater than 300. So again, depending on where you practice, you may be encountering these types of patients. So this will be an instance where you can go ahead and start off with insulin therapy, which we'll talk a little bit more about initiating insulin and everything. But just keep that in the back of your mind too, that I said it's pretty clear cut. Everyone gets metformin straight off, but you also need to be thinking about if a person's really bad, as far as their A1Cs is really high, they may need to go ahead and start them on insulin and in combination with metformin maybe, or maybe start them on, a couple therapies or whatever. And these last two parts here are just a little review of mechanism of action, but you guys have that from the other presentation. Some advantages of metformin: it is weight neutral. It can cause some weight loss in some people, so that's kind of it's just really going to be patient specific on that one. Side effects, just common adverse effects. When you think of metformin, think of GI adverse effects. So definitely it's common adverse effects. I want you guys to make that connection with metformin. The good news is those typically go away. I say typically because, in the pharmacy, we have people complain a lot about adverse effects, side effects. And so definitely had the patients where it's transient in the pharmacy, but then they've also had some that just it never goes away. So again, it's just going to be kind of patient specific. But for testing purposes, studying purposes, GI adverse effects common, and then they usually go away. The other thing to note too with long-term metformin use, you can have vitamin B12 deficiency. So please note that when you're studying. And so they recommend to monitor vitamin B12 serum concentrations periodically with long-term therapy. And this monitoring of the B12 should be considered in all patients that are receiving metformin, and in particular those who have peripheral neuropathy or anemia. So those are the two specific patients that need to really be monitored for. So what you do with these patients is you prescribe a supplement, a vitamin B12 supplement for them. Just again, for review purposes, make sure that you have everything for studying. When you're studying metformin, I just listed here some risk factors for metformin-associated lactic acidosis. Again, that's a boxed warning. It's very serious. I want you guys to have that mental link when you are studying these things. So definitely go ahead and read through here. And you'll note too, this is where I said that some of this sort of the art of medicine comes in, and you'll have to look at your patient vignette when the question. So I mentioned earlier excessive alcohol intake or having liver impairment. Those are some instances where maybe it wouldn't be good to have metformin or whatever. And again, it's going to depend on the patient, but also too, you have to be mindful of drug interactions with this metformin-associated lactic acidosis, specifically the carbonic anhydrase inhibitors. So you guys remember those, hopefully, from the cardiology module. And those are things like acetazolamide is an example of that type of drug. So please be mindful of that. That can be certain drugs can actually make this condition worse. And you'll notice here too, there is having a radiological study with contrast. So basically you have to stop before iodine-based contrast dye testing, and then you can resume safely 48 hours after if the renal function is okay. Next steps. So what do you do next? Like I said, this is where we get kind of not as clear cut. Sorry, so apologies. And I'm not laughing at you guys, I'm laughing with you guys because it drives me crazy too. So it's not, so anyways. Okay, so if non-insulin monotherapy at maximum tolerated dose, so that's usually 2,000 to 2,500 milligrams of metformin, by the way, FYI, is not tolerated, or I'm sorry, does not achieve or maintain the target hemoglobin A1C after 3 months, then you add a second oral agent or insulin. And like I said too, if the patient is severe enough initially, you can add insulin. So this basically means metformin plus what? Plus one of the 6 available treatment options. We have them listed there. Including that is basal insulin. And the reason I keep going back and I keep repeating myself and saying basal insulin is because a lot of students and kind of earlier practitioners will forget that basal insulin is part of your, and that'll be also to kind of connect to the presentations. That's like rapid acting insulin. So your basal insulin, I'm sorry, not rapid acting insulin. Scratch that. I'm sorry. That was basal insulin is the long acting insulin. I'm sorry. Basal insulin is the long acting insulin. But the reason I mention that is because patients do not like insulin, and then it's just something that they're very resistant to, whatever, but it may be warranted, again, depending on the severity of the patient. So here's a good visualization tool I like a lot. I like these with these organizations and these guidelines come out. I usually like their tables and figures and everything. This one in particular I like, and I believe it'll help for studying purposes for my exam and then also for ICM. But so this is just basically a visual representation of what we're talking about today. Notice here, everyone starts with monotherapy unless we have these two things. We have the A1C greater than or equal to 9%. It's considered dual therapy. So that has this little orange arrow, hopefully you guys can see, jump down to dual therapy. And then if the patient has an A1C greater than or equal to 10, blood glucose greater than or equal to 300, and they are symptomatic, then they jump to a combination injectable therapy. So anyways, and then so we have monotherapy. You notice lifestyle management is here all along. So at the beginning, at the end, at the always, no, that's not proper English. But yeah, so always lifestyle modifications. Metformin, you notice there, it's always there. Again, less contraindicated. So metformin is a big player. And then mono, dual, triple therapy. So, and again, this is where it's not just one thing, metformin, then always you add this, I always add this. So, it has basically some pros and cons of each of the categories here. So, it says efficacy is the top one. Hypo risk, which means hypoglycemia risk. Weight, does it cause weight gain or weight loss, or is it weight neutral? Side effects, what are the big, main concerned side effects? Cost is another one too. So how much does it actually cost the patient just out of pocket? That's a financial cost, not like a cost if, anyways, there's other ways to describe, that's financial cost. And then it talks about if the A1C target is not achieved in 3 months, blah, blah, blah. So this is a great slide. I would definitely encourage you guys to read through this. I think it'll help with studying. I think it'll help a good review for side effects. Does it weight neutral, weight loss? Does it cause weight gain? Lots of good stuff. I can't say enough good stuff about this. But this is from the ADA, by the way, American Diabetes Association. If you are having trouble with this image or whatever, let me know and I'll try to get you a better copy of it. But I believe it's pretty clear, and hopefully it's clear enough for you guys to read. And I would encourage, I know you guys are super busy, but I'd encourage you guys to try to maybe look at the new ADA guidelines for yourself to kind of, maybe there's some other tables, maybe there's some other stuff in it that you guys like that I don't. And by the way, too, not that I want you guys to do my job for me. Yeah. But I always appreciate it when students come across, things that they like or that they study. So in the past, there's been, not this chart in particular, but there's been charts and things and guidelines that I didn't think were maybe that great, or I didn't like. And then students are like, no, everyone likes it. And so, yeah, definitely if you come across anything else in the ADA that you'd like, for me to know about, that'd be great. And continuation with this one, so you'll notice that if it's very severe, it goes down here, the combination injectable therapy. So the second page here is the combination injectable therapy for type 2 diabetes. So this is where you go with initiate the basal insulin, usually with metformin and or other non-insulin agents. So that also has a lot going on. So hopefully you guys can read this one as well. Please let me know if you're not able to. And like I said, I unfortunately misspoke before, so hopefully it's clear for everybody. It's initially with that basal insulin, which is that long-acting insulin. So that's going to be like with your Lantus or Levemir, which are brand names, by the way. And then you're going to go down and so do that 10 units a day, make your adjustments. Are you having hypoglycemia or not? Is the A1C controlled or not? Then you can go to some other things. If you then can add a rapid-acting insulin before the largest meal. So that'll be like your insulin, the aspart, for example, is one. So anyways, yeah, I don't want to read this whole slide for you guys, but I show you kind of the flow of what, if it works, what do you do? And if it doesn't work, what do you do? If the goals are met, or if they're not met, what all do you do here? So, yeah, so again, hopefully this will be beneficial for studying purposes. Again, a lot going on in these two visual guides. And I know you guys are super busy and everything, but hopefully this will help kind of condense things and kind of focus things. And I'm also kind of biased because I'm more of a visual learner. And so these were things that would always help me for exams, because I could kind of go back and think of where things were laid out and, how the algorithm was flowing and everything. So anyways, a lot of good stuff on both of these slides. So definitely please spend some time reading through them in their entirety. Okay, so metformin, we got, it's easy. All right, what do we do next? Okay, so these next slides are just me kind of a little bit of review, but also kind of some pros and cons of some of these second and third line agents. First off, we have these sulfonylureas. Have them listed there with their brand names, and just a little, I guess, I don't know if I should say fun facts about them, but mechanism action review, they increase insulin release. You have to be concerned with these. So definitely a star here with hypoglycemia. With all the anti-diabetic agents, you have to be concerned with hypoglycemia, but some are worse than others at causing that. And you'll notice going back here too, they have the hypo risk, so that may be beneficial with for studying purposes. And that's let me show you one other thing too. So yeah, with the sulfonylureas, you notice it has the moderate risk, and it's in comparison to insulin. So you notice insulin has excuse me, the highest risk with hypoglycemia, but again, just something to be thinking about and to be mindful with all these medications. It's kind of neutral when it comes to the cardiovascular risk. It isn't necessarily good or bad with that. The first line sulfonylurea is going to be your Amaryl, which is glimepiride. This is the preferred agent of this list. So again, for studying purposes, if you want to put a star right here by this one, this is going to be your first line. If you are going to go with the sulfonylureas, and again, this is where students don't like this when I tell them that, because it's a lot of ifs and ands and, again, patient specific. So anyway, so yeah, this is going to be your first line one. It is shorter acting. You don't have to worry about renal elimination. And then here's the dosage, just FYI on that one. Then we have the TZDs, pioglitazone and rosiglitazone. This is an alternative to sulfonylureas if no cardiovascular or bone fracture risk. There's also concern with these. They may cause bladder cancer and longer term chronic use. There's been some animal studies done on that, but anyways, so just FYI on that. Then we have the rapid secretagogues, the Prandin and Starlix. These can be beneficial for patients who have the sulfa allergy, who have irregular meal schedules, or those who develop late postprandial hypoglycemia when they are taking the sulfonylurea. So anyway, something to think about there. Other drugs. So here's a long list of other ones. These other drugs aren't going to be usually your first ones you're going to want to go with for your second and third line agents, just because they're not super efficacious. They have to be administered a lot more frequently, so patients don't like that. There's a lot more potential for side effects and drug interactions with these here. These two, it's going to be patient specific. Nothing really, good or bad to say about them. It's going to really depend on that patient. Same thing with the gliptins here. And then the non-insulin injectables are very expensive, so that's something to be mindful of when you're prescribing these. The Flozins too, not really, some of these are with these newer agents. They haven't really stood the test of time, so to speak. So the sulfonylureas are a lot older, and they're cheap, and there's a lot more experience with them. So that's part of the reason why you can go with those. But really, and again, I hate to keep saying this, it's going to depend on the specific patient. So sorry about that, guys. I keep saying it just depends on the patient, but yeah. So just as a kind of the summary and recommendations section here, if anyone who's newly diagnosed with diabetes should definitely try to do the lifestyle modifications. So we have some specifics here, and again, it's going to be kind of patient specific. Where do they live? Where do they work? What do they do for a living? What kind of access do they have to food or to exercise, etc. And like I said, at the least, if the person can move more, eat less, and stop smoking tobacco, that will be beneficial for them. And then you can get into more specifics with your patients as far as what to do. But it is also, you remember that the ADA does recognize that you do need to start with the medication initially, so that this is one where it's lifestyle modifications plus medication. This is also noting here that this should be an individualized, kind of tailored approach to this patient. So because you don't want hypoglycemia, you don't want those complications, but then you also don't want hyperglycemia. So anyway, so that's usually where most patients you're going to settle on the goal of less than or equal to an hemoglobin A1C less than or equal to 7.0. So it's just going to kind of depend though too. Are they older or younger? Because that can also make you, if they're a lot older and they don't have that high of an A1C, do you want to be that aggressive? Because a lot of times the benefits of being aggressive and treating your blood glucose is for, that it's a chronic benefit. It's for a long-term benefit. So older adult who has maybe a hemoglobin A1C of 8, do you want to be super aggressive with them? And then you have to think about, well, their kidney function, liver function, and then you have to think about adverse effects and their quality of life, etc. So again, it's going to kind of depend on the patient. We talked about metformin as being first line. Contraindications here are listed. And then just to FYI for you guys, there was a recent change in 2016 about the labeling requirements for metformin. So basically, long story short, they got a little less strict with them, but we, for study purposes, still learn about the boxed warning, etc. But here are the newer recommendations: metformin containing products, and so it's basically related to the kidney function. But definitely read through these; is to be good stuff. But I'm not going to. I mean, you don't have to memorize this necessarily. Just read through it. Make sure the take-home point. That there were changes made, and that they and you do need to be mindful of the person's kidney function when initiating this. And again, it's related to the contraindications we talked about earlier with metformin. And so the other thing too with lifestyle modifications that goes a little bit against what the ADA said is that you can, if a patient is heavily motivated. So this has happened in my family. Type 2 diabetes, unfortunately, is in my mom's family has a pretty strong familial presence on my mom's side. And there have been family members on that side that have been motivated to, get their blood glucose down without medication. And so it is reasonable, and they were successful, luckily. So it is reasonable to give a patient 3 to 6 months of lifestyle modifications if they are very adamant and very motivated to do the lifestyle modifications. So it's going to be, I don't want to say it's a rarity, but it's going to be a select group of your patients. So, but so anyway, so if when you're talking to the patient and they're resistant to getting on medications, it's not unreasonable to give them 3 months, before prescribing them something, maybe 3 months, 6 months, and check back with them and see if they've, if their A1C's gone down. Because the interesting thing about type 2 diabetes is that it is a modifiable disease in the sense that, and I was hesitating a little bit there because some people get really mad when some patients get really mad, but it is something that's modifiable with their lifestyle. So, my thing's like, more power to you if you want to do it without drugs. That's cool. I mean, I'm a pharmacist, but you don't have to do drugs to be my friend. No. But yeah, you don't have to necessarily prescribe something right away. But it's going to be patient dependent too. So I'm again hesitating because the hemoglobin's A1C is 10 or something, and their fasting blood glucose is 300 or whatever. It can get kind of crazy or whatever. So anyways, yeah. The other thing with metformin dosing, I talked about the max dose earlier. You typically titrate up the dose. So you don't typically start the patient off on 2,000 milligrams per day. One is for the side effects, and like I mentioned, GI side effects, right? But yeah, so you typically, excuse me, I catch my breath there. Typically, I'm trying not to sneeze on you guys too. Typically, you start them on a lower dose, so 500, maybe BID, 500 milligrams twice a day. And then you can work them up to that 2,000 milligrams per day. And it's usually in a divided dose. So 1,000 milligrams in the morning, 1,000 at night, twice a day. Mentioned insulin can be used first line. And again, with those, higher A1C patients, that can be something. If the patient, and this is also kind of, I didn't talk about this before, but if a patient just automatically has a contraindication to metformin and you want to just do monotherapy, then you would want to go with sulfonylurea, and specifically the Amaryl, which I mentioned, as the initial therapy. And it's cheap, it's generic, and it's usually well tolerated. So anyways, I'll let you guys read through the rest of that. If a person cannot take metformin nor the sulfonylurea, so they have a sulf allergy and they're contraindication to metformin, then you can go with something like Prandin, maybe. And then we have some other oral and injectable agents. They may be appropriate, again, depending on the patient. However, these are limited clinical experience, and that's what I was saying too. These are newer drugs, and so we don't know them as well as some of the older ones like the sulfonylureas, and metformin, and then also the cost of some of these newer agents. So The pioglitazone I mentioned too before. It is also generic now, so it is relatively lower cost. But then that is something you have to be considerate of, that the pioglitazone does have a risk of heart failure, fractures, and then the increased risk of bladder cancer is one of the things that, some of the things to think about when prescribing that. Especially too, like if it's an older person, with a bit fracture risk is a bit, or if they have cardiac issues or they're already prone to having heart failure or whatever. So yeah, and that's what I'm saying. It's going to depend on that full picture. So board style question or whatever talks about a patient who has heart failure and is elderly and has had a bad fall in the past or whatever, or has osteoporosis or something. This would be rationale to not pick the pioglitazone, for example. And that hopefully helps you guys when I'm saying that it's going to be patient specific. And then, we try our best when we're writing these exam questions to kind of make it, or at least for myself, I try to make it as kind of as clear as I can without telling you the answer. But, so like, patient has a history of heart failure, fracture history, osteoporosis, blah, blah, blah. It's like, well, please don't pick pioglitazone for this patient. This is just saying too that, you wait 2 or 3 months. Like I said, that's why the reason I like the, that ADA algorithm that I showed you a few slides back that kind of tells you, if you met your goal, good. If you haven't met your goal, 3 months, do this. Here is another indication here to initiate insulin if the patient is symptomatic, they have weight loss and severe hyperglycemia. You can go ahead and start with insulin. And if the patient does have severe hyperglycemia and they do not have the ketonuria, you can do a high dose sulfonylurea if they do not want to take the insulin and they're very adamant about that. But, again, going to depend specifically on your patient. One thing too, especially with your younger patients that you are suspecting of type 2 diabetes, you definitely need to make sure that they don't have type 1 diabetes, because with type 1 diabetes, like I mentioned before, they're going to definitely need that exogenous insulin. They're going to definitely need insulin. So that's just part of and I'm not good at diagnosing, and I believe you'll be learning that in ICM and your other courses, but so definitely make sure with your differential diagnosis that, this person really does have type 2. And like I said, it's going to be more difficult usually with your younger patients and you're trying to figure out, do they have type 1 or type 2? And if you can't tell for whatever reason, you need to give insulin then if you're not sure if it's type 1 or type 2. This is just the recommendations on obtaining A1C at least twice a year, and then maybe more frequently if a person is not meeting their goals, or if you're changing therapies. So this is with the oral medications and with insulin. You definitely need to stay on top of that. So quarterly then. Anyways, let you guys read through the rest of that. And that is the last slide there that I have. So thank you guys for your time and attention. Please email me if you have any questions, comments, or feedback. And I will talk to you guys later.